So we might move on to our next speaker now, and I'm very pleased to be able to introduce Professor Markus Seibel. Professor Seibel has been the head of Department of Endocrinology and Metabolism at Concord Hospital since 2003, and is the inaugural director of the Bone Research Program at the ANZAC Research Institute. He's also an avid, extensive researcher with research around osteoblast differentiation and signalling, transgenic models of bone disease, metastatic bone disease, osteoporosis, bone and mineral metabolism, and vitamin D and biochemical markers for bone turnover. In January 2021, Professor Seibel was also appointed a member in the Order of Australia, AM, for significant service to medical research and to endocrinology. And I'm very pleased today to welcome Professor Seibel to speak to us about atypical fractures.
Thank you very much, Catherine. I'm just going to minus the screen. There we go. Can you see that? Yes, I hope so.
Yes, we can.
Good, thank you very much. So I'm going to talk about atypical femur fracture, and I will talk a little bit about the history of that whole thing, and then move on to the epidemiology of, as we call them, AFFs. So I'm going to use that abbreviation quite often because atypical femur fracture is a little long. So epidemiology of AFFs, and particularly the association with bisphosphonate therapy. I will then talk a little bit about key features. So what do they look like? How do we recognize them? There are ASBMR criteria which I'm going to touch on briefly, and I'm going to end with a few remarks on clinical management. So going back in history to 2007, my then patient, 73-year-old Asian female who had osteoporosis and because of several previous fracture had been treated with alendronate for 18 months. She was then referred to us by her GP because she was complaining of bilateral groin pain for the past year or so. And when we investigated her on a whole bone body scan, on a whole bone scan, we could see this focal uptake here in the right femur, and if you look carefully, unfortunately it's been cut off here, you can also see some focal uptake on the left femur. So here's an x-ray of her right femur. You can appreciate that the femur is a little bit bowed, but you particularly note this thickening, this focal thickening here in the lateral cortex. And if I magnify this, you can see that there's not only thickening, but there's also this black line here, and we call this the dreaded black line because this is indicative of an imminent risk of fracture. I saw her, she was admitted to hospital with bilateral femur fractures, and you can already see that these bilateral femur fractures look different from what we normally see, but I'll come back to that in a moment. We published at the time, we published that case with a bit of a lengthy title, but we didn't realize that we were looking at a completely new breed of fractures. But already a year later, other people, Vizakruna and his colleagues, published 3 cases of these, what they called chalk stick.
Professor Seibel, I'm just going to
quite well, and they remarked that these, yes.
Professor Seibel, I'm just going to interrupt. It's a little bit difficult with the internet. I might just get you to turn your video off, and we'll just see that a little better. Thank you.
Is that better now?
Yeah.
Okay.
Go ahead.
We unfortunately, Concord Hospital's IT systems are not really up to scratch. I'm sorry to say.
We can hear you now.
Is it better now?
Yes, that sounds good. Thank you.
Okay. So they already noted that these fractures looked different from what we normally see in terms of hip or femur fractures in osteoporosis. They used the word atypical for post-menopausal osteoporosis, and they noticed that biochemical markers of bone turnovers were quite low. And in the same year, Nevasier then published 70 cases of non-hip femoral fractures, and they used for the first time really the term atypical fracture pattern, and they defined it right away, saying, okay, there is a simple transverse fracture through the cortex, through the lateral cortex in an area of cortical thickening or hypertrophy, as they called it, and they noticed this unicortical, in the usually medial beak. And of those 70 patients, 25 were on alendronate. And for those on alendronate, that fracture pattern was quite typical, i.e. 96% of them had it. And since then, the number of publications has gone up. It's, as you can see, it's basically an exponential increase in publications on AFFs and the association with bisphosphonate therapy. And in 2014, the ASBMR, the American Society for Bone and Mineral Research, put together a task force who looked at all these publications. And I'm just going to show you an extract here with a few of the studies they analyzed. And as you can see, they're from all over the world, the USA, Australia, that's our own study, Netherlands, Europe, the US, Switzerland here. And the table shows very clearly how variant these data were. There were, this applies obviously to the number of patients looked at from 41 to 1,200, but it also shows how the number of patients with atypical femur fractures, and again, the relative risk for those patients who are on bisphosphonate, the relative risk for AFFs, how these numbers differ between those publications. And that was just across the bench. You can see, for example, the relative risk for patients on bisphosphonates as opposed to those not on bisphosphonates to suffer an atypical femur fracture varies, according to these studies, somewhere between 15 and 69. I would like to turn note that two studies actually came quite close to the number that is now widely accepted. And that study is our own, which was a relatively small study, but then also the study by Schilcher and his colleagues from Sweden. And I want to talk a little bit more about that study because I believe that that study is still the best we have so far. So Schilcher and femur, importantly, they did an individual X-ray review. They looked at every single X-ray, and that is very important because there have been studies about atypical femur fractures where the researchers and authors just relied on reports, on radiology reports, rather than looking at the images themselves. And you cannot define, you cannot recognize an atypical fracture unless you look at the image and define and find those fractures that I've just talked about and will talk about in a few minutes. So Schilcher, going through the somewhat labor-intensive review of all these X-rays, defined 59 patients with atypical fractures, and nearly 80% of those had received a bisphosphonate. And they defined, as I just said, the relative risk of the oral or IV as 33, very close to what Christian Goerges and our group has shown a few years earlier. They also made two very important observations. And one is that the risk of atypical femur fracture increases the longer you treat with a bisphosphonate. And I'll show you data on that in a moment. And the risk of atypical femur fracture falls very quickly. They say 70% per year. That obviously varies between studies and patients after ceasing bisphosphonate therapies. Very important to relative and absolute risk. If we talk about relative risk, and that is the risk of an AFF in patients on continuous bisphosphonate therapy compared to patients who are not on continuous bisphosphonate therapy, that relative risk is very high for those patients on continuous bisphosphonate therapy, about 30 to 40-fold. We also have seen reports of AFFs in patients treated with denosumab, but unfortunately at the moment we're not really sure what the incidence of AFFs in denosumab-treated patients is, particularly relative to bisphosphonates. My own gut feeling is that it is very similar to bisphosphonates. In contrast, the absolute risk of suffering AFF in patients treated with bisphosphonates is very low. It's about 3 to 50. Again, you can see there is this large variability, about 3 to 50 per 100,000 person years compared to the incidence of typical hip fracture, if you like, of about 350 per 100,000 patient years. So very clearly, the risk-benefit ratio is very much in favor of treatment. And a recent study by Dennis Black from California has again re-emphasized that, if you like. And they, as you can see here in this slide, looking at white women, they found that years of treatment here with a bisphosphonate prevented 1,360 clinical fractures, and 591 of those were hip fractures, whereas 38 cases of atypical femur fractures were observed. So that's very clear that, you know, we see 38 versus 1,300. That is very clear in terms of risk-benefit ratio in favor of treatment. That is for white women. However, for Asian women, this looks quite different. As you can see here, the number of clinical fractures prevented is somewhat lower. That is also true for hip fractures, but the number of atypical femur fractures caused during treatment, years of treatment, is much, much higher. So here the risk-benefit ratio is still in favor of treatment, but it is not as good as seen in non-Asian ethnicities. And that leads us to what are the risk factors for atypical femur fractures. And as I said before, from the Schilcher study and other studies, we know quite well that duration of treatment is an important factor. The longer you treat, the higher is the risk. You can almost see that it's almost an exponential rise here in risk. Now, this is years. And as I mentioned before, the risk drops very quickly once you cease treatment with bisphosphonates. And note, this is not years, but months. So within 3 months of ceasing treatment, the risk goes down, and then certainly within a year and 2 years, the risk further drops down. Also, as shown by Black's study, but also by other studies that have been published in recent years, Asian ethnicity is a major risk factor. As you can see here, the risk of AFFs is 6.0 for Asian ethnicities, where it is ranges between 0.2 and 1.2 for Black, white, and Hispanic populations in the United States. That is, it's maybe different in other countries, but this is the data we have. Also previous glucocorticoid use. Patients with AFFs are usually somewhat younger than our say common hip fracture patients. And I would encourage you to look at Christian Gerger's recent publication in the JBMR and his Sydney AFF score, which takes into account femoral geometry in calculating and determining the risk of hip fracture in our osteoporosis and bisphosphonate treated patients. So very quickly, the key features, so you can spiral fracture here, the spiral pattern indicating high impact of force, whereas in contrast, this is a typical atypical fracture with the transverse fracture through the lateral cortex, the thickening of the cortex, and the medial beak. And I repeat that again because this has been known for a long time. Leonard Nevasier, many years ago, have defined these features. And then again, the ASBMR has come up with major and minor features. So the major features are listed here. You need 4 of those 5, obviously little or no trauma. The lateral cortex is involved with a mostly transverse fracture. No comminution. A complete fracture may have a medial spike. That's not always the case, although I must say 99% of the cases I've seen, there was a medial spike, and the thickening is quite typical. There's also minor fractures, which I'm not going to go through, except mentioning this here: prodromal symptoms, pain in the groin or thigh. You remember the patient I mentioned at the very beginning? This patient had pain in the groin for 10 months before she suffered those bilateral fractures. And I encourage everyone who's treating patients with bisphosphonates or with denosumab to always ask about those prodromal symptoms, because up to 75% of patients with incipient or developing AFFs present with these complaints. So they're often ignored or put as osteoarthritis or something unspecific, but this is actually a very important prodromal symptom which we should take very serious. Finally, some words about management. In terms of management, we obviously distinguish between complete fractures and incomplete fractures, and I would also like to point out that it's worthwhile looking at stress reactions in these patients, as shown here, where there is no clear lucency, as for example here, but where you can already see there's something going on in this bone. So in terms of complete fractures, obviously we stop anti-resorptive therapy and we send the patient to the surgeon for a nail. It's always good to not just monitor or image the side where the fractures happen, but also image the other side. Up to 25% of AFFs happen bilaterally. And particularly if you see signs of stress, and I'll come back to that in a moment, it's always worthwhile considering a prophylactic surgical fixation if there are signs on the other side. Some people, and me included, in some cases consider anabolic therapy, bone anabolic therapy, that is, with other words, teriparatide. There's some data there, not a lot. It's mostly anecdotal or small case numbers, and we have no data for romosozumab. In terms of incomplete fracture, that's always a little bit tricky. If there is no lucency, if there is no dreaded black line, you can try treating these people conservatively. Obviously, again, we stop anti-resorptive, but continue vitamin D and calcium if the patient needs them. And we consider bone-forming agents such as teriparatide. If the patient is more or less asymptomatic, we usually recommend limited weight bearing. And we check after 2-3 months on MRI whether edema is still present. If edema is still present, or if there is now the appearance of a lucency, then we usually send those patients to the surgeons for prophylactic surgery. And we do the same thing for patients who are in severe pain, because we know that those patients often break very, very soon. Finally, what are the implications for the management of patients with osteoporosis? As I said, please take those prodromal symptoms serious. Always ask about them. And if you have patients who present with these symptoms, please consider imaging of both femora, not just the side where the pain is. Clearly, avoid anti-resorptive therapy in patients at low fracture risk. You're going to do more damage than good, because at patients at low fracture risk, the efficacy of treatment is low, but the risk, the absolute and of course the relative risk of AFF is still the same. It is low in terms of absolute numbers, but it is an unnecessary risk in patients who have a low risk of fracture to start with. And the same thing again in terms of drug holidays. Yes, this is a controversial area, but given that the risk of AFFs, as small as it is, given the fact that it is increasing with the time of duration of treatment, it does make sense to consider a drug holiday from time to time, or you can also stretch the interval if you're using intravenous bisphosphonates such as zoledronic acid. You can stretch the interval of treatment and thereby lower the total administered dose per time unit. And that's all I have to say. And I'm happy to take questions.
Thank you very much, Professor Seibel. It was a fantastic presentation. I remind everybody to send some questions through to Slido. We have one there already. In patients with a previous atypical femoral fracture who don't qualify on PBS for the teriparatide, are there any other options for osteoporosis management?
Unfortunately not. You're absolutely right. The treatment with teriparatide or maybe romosozumab on the PBS usually requires a very low T-score. In most of these patients, they already have fractures because they are on treatment and now they have another fracture. So if their T-score is low enough, they do qualify on the PBS. Unfortunately, in Australia, there is no other option. Sometimes I have one or two patients where I very carefully, after maybe a year or a year and a half or so, start them on permidronate, on very low dose permidronate, and hope for the best. I obviously have absolutely no evidence to justify this, but it's basically an approach, a little bit is better than nothing, but whether it's effective, honestly, I do not know. One trick I can, many of you will know that, is if your patient had a fracture and then fractured again with an AFF and their bone density is not low enough, i.e. less than -3 for teriparatide, do their distal radius, that often comes back with -3, or do a QCT that also comes back off much lower than what you get with the DEXA. But don't say that I said that.
Yeah, okay. All right, thank you. A really interesting question has come through regarding the patients who are on continuous sort of long-term bisphosphonate use. Do you think there is a role for routine screening of plain x-rays with these patients, or should we just be doing it symptomatically?
Yeah, no, there is no use for routine screening. One thing you can do is, and we tried this for a while, is to do a DEXA with an extended hip. So you basically scan down the femur as well. And you can see if you have a good DEXA machine, you can spot thickening of the cortex, of the lateral cortex. And obviously that's something you would then follow up, but you can't see lucencies or any insufficiency fractures or anything. So the short answer is no, it's not worth it. But as I said, please ask your patient, because not every patient tells you about groin pain and femur pain and so on. Ask your patients about these symptoms, and you'd be surprised how often you actually do get a positive answer. And I do follow up on those patients, and I would say that in up to 50% of those patients who really have those symptoms for longer, I find something.
Okay. I've got a question myself about the decreasing risk, the effect of the drug holiday. So you have a patient who's been on long-term therapy greater than 5 years. So you demonstrated a slide that showed a significant increase in atypical fractures after that group. How is their risk adjusted if you do then give them a holiday, and how long should that holiday be?
How long is a piece of string, Catherine? That's one of the hard questions. Nobody has our data for that. There is no evidence for that. One thing we know is that if you look after your patients and you assess their risk basically every time you see them, say once a year, every other year, whatever, you assess their risk and you see that, you know, they've been on, say, bisphosphonate therapy for 3, 4, 5, 6, 7 years. And if their risk, if their bone density, say, has been stable, they had no new fractures and there are no new risk factors, I tend to propose a treatment holiday with bisphosphonates, obviously you can't do that with denosumab or Prolia, but with bisphosphonates you can do that. And I must say, I mean, I'm probably, there's people who would clearly say I'm wrong, but I must say I'm a great fan of drug holidays with bisphosphonates, with long-acting bisphosphonates, because they are effective and they have these long-lasting anti-resorptive effects, and you do lower the risk of AFF.
Great, and we've got one final question from the chat, and that is, what is your management of AFF patients on denosumab, pardon me?
That's a very, very hard question, and I can tell you I don't have the answer to that, simply because I've never had a patient on denosumab with an AFF. Theoretically, obviously, you would have to stop the Prolia, which is in itself a problem, particularly after long-term treatment, because as you all know, once you stop Prolia, bone turnover goes through the roof, bone density goes down, fracture risk returns to baseline, and for some people, a small group of people, there is an increased risk of multiple vertebral fractures. So we all know that. In the end, you know, if a patient had an atypical femur fracture on denosumab, you have no choice but to stop that treatment, and there's really not much else you can do.
Thank you very much. We might wrap it up there. Thank you so much, Professor Seibel, and also Dr. Tarrant, for that great session this morning.